Hi guys, welcome to another episode of the OMFS Survival Guide and Crash Course. Today we're covering sepsis screening. My name is Shona Garland. I'm one of the secondary medical students just going into my final year, and I'll be taking you through the cases today. So as always, we're going to go through the aims and objectives. So we want the participants to understand and apply the sepsis screening pathway in real life cases in the context of MaxVax DCTs. We want you to understand common causes of sepsis in MaxVax patients, be able to recall the sepsis 6, and understand when to seek help with these patients. And it's also important to be aware of initial investigations as part of assessments in these patients. Okay, so let's get started. So case 1. You're the daytime on-call DCT, and you're called by the nursing staff to assess a 49-year-old male who's on the ward. And this patient is complaining of palpitations and dizziness. So palpitations just mean they feel like their heart is beating out of their chest. So what other information do you think you would like to get over the phone? It'd be good to get some observations from the patient. You'd like to get some background on the patient's admission and their treatment. Also good to know about the patient's past medical history. Is that going to influence the patient's presentation? And do they have any allergies if they know that? And any investigations you think you would ask for while you're walking over. So you probably want to get an ECG, that's because the patient has palpitations. And you may also want the nursing staff to get you some bloods as well if they can. And finally, what do you think could be some differentials which could be causing this? Think about what could be causing the heart to be feeling like it's beating out of their chest and for the patient to be dizzy. So you want to be thinking about this as you're walking towards the patient. So you managed to find some background information on the patient. The patient was admitted with a right-sided submandibular abscess, and he's currently on IV comoxiclav for this. Medically, he suffers from type 2 diabetes, he has gastroesophageal reflux disease, he has hypertension and diabetic retinopathy, which is going to be secondary to the patient's type 2 diabetes. Drugs-wise, he's taking ramipril, omeprazole, metformin, gliclazide and insulin. So that's an important bit of information that the patient is taking insulin. Their diabetes has progressed so much that they're no longer producing sufficient insulin despite being not being type 1 diabetic. The patient doesn't have any allergies, and the patient's a non-smoker who occasionally has alcohol and currently works as a postal worker. So with this background knowledge, do you have any ideas what may be precipitating the patient's symptoms? So you want to think about the different information you've been given. The patient has an abscess. Could that be participating the symptoms? Anxiety can cause patients to feel like their heart's beating out of their chest and give them palpitations. Could the patient be septic? Is there anything in the medical history which might be causing it? You want to think about all these things. So you've got some observations for the patient. You can see that his oxygen saturations are 97% on room air. He has a blood pressure of 95/65, a heart rate of 105, a respiratory rate of 18, and a temperature of 37.9. So what do you think of these? We'll work through them. So his oxygen saturations are normal. He's oxygenating fine on air. His blood pressure is 95/65. That's low. That's low, and that's concerning for this patient. And he also has a tachycardia. So this patient is hypotensive and tachycardic. His respiratory rate is okay, and his temperature is 37.9, which is technically a pyrexia. So you put the hypotension, the tachycardia, and the pyrexia together, and what may this patient have developed? You want to be thinking about sepsis. We also need to remember that patients who are immunocompromised, this patient probably has poorly controlled diabetes. That makes this patient immunocompromised, and the elderly don't always spike temperatures. So that's something to bear in mind. So what is sepsis? Sepsis is a life-threatening organ dysfunction due to a dysregulation of the body's response to infection. So its potential sources are the chest, the abdomen, the urinary tract, skin, soft tissue, and obviously very relevant to us, teeth can also be a source of infection. The initial course is variable. Some patients won't deteriorate beyond SIRS, which is a systemic inflammatory response, whereas other patients will rapidly deteriorate to organ failure, which is severe sepsis. So patients with 2 or more of hypotension, so that's a systolic blood pressure of less than 100, altered mental state, so a GCS less than 15, tachypnea, so high respiratory rate, more than 22, the mortality rate increases to around 40%. And that's why it's really, really important to be super aware of this condition and initiate the correct steps in trying to prevent it and treat it as early as possible. So what is the pathophysiology behind sepsis? So patients with sepsis become hypotensive as the cytokines are released to fight infection cause vasodilation. So they cause the blood vessels to dilate. And this leads to a lack of peripheral resistance because of the dilated vessels, and this leads to a blood pressure drop. If you have a local infection, this is useful because this vasodilation increases the blood flow to the area, and it allows all the immune cells to help fight the infection and get there faster. But in sepsis, it's a systemic response. The entire body responds this way. So the vasodilation occurs everywhere. The same cytokines also cause some inflammatory damage to the alveoli in the lungs, and that makes air exchange less efficient, and it causes the raised respiratory rate. So the reduced oxygen and the increased inflammatory and bacterial degradation products cross the blood-brain barrier, and that contributes to the confusion that patients can have in sepsis. So that's how it all happens. What is septic shock? So septic shock is sepsis with a patient who has a serum lactate of more than 4. Now lactate is a byproduct of anaerobic respiration, and it's a marker used in sepsis. Or it's hypotensive, unresponsive to fluid resuscitation, and has a high mortality rate of around 50%. So that's what sepsis is. So you all should have heard of the Sepsis 6 before, and there's a handy acronym to remember what it is. So there's Buffalo, so the first one is blood cultures, urine output, fluids, antibiotics, lactate and oxygen, and those are the Sepsis 6. You can also remember it as 3 in and 3 out. The 3 in will be fluids, antibiotics and oxygen. The 3 out will be blood cultures, urine output and lactate. So going into a little bit more information about it, starting off with the oxygen at the bottom. So the hypotension that you get in sepsis, you get disordered capillary beds and microthrombi in the lungs, which compromise your oxygen delivery to the tissues. So giving high flow oxygen during the initial resus, you always give them 15 litres straight away, straight off the bat. Even if the patient has a background of, say, COPD, this doesn't matter. Even if they're a CO2 retainer, you still give them high flow oxygen in situations like this. Some patients you may want to consider intubation if they're showing signs of fatigue or cardiorespiratory compromise. Moving on to the blood cultures up at the top. So you want to take a set of blood cultures, but you may also want to think about any other samples that you could take. As a patient showing signs of a urine infection, you want to take a sample of that and send that off. You want to take a sample of the fluid specific to the presumed source of infection before you start the antibiotics. You also want to try and get the blood cultures before you give the antibiotics, because it might clear out the bacteria, and you might not grow anything. But it shouldn't delay you giving the antibiotics. So you really want to try and get it done as soon as possible. If the presumed source of infection is amenable to control, like drainage, like a submandibular abscess, you want to complete this as soon as possible and within 12 hours. So antibiotics, you generally want to give them broad spectrum antibiotics and as soon as possible, and always within the first hour of the patient presenting. You want to check your local guidelines about what you're going to be giving these patients. So fluids. So if a patient has circulatory shock, and that results from a combination of the vasodilation of blood vessels and the hypovolemia, so not having enough fluid in them, and that's the most common form of organ dysfunction in sepsis. Give these patients fluid challenges and boluses of 250 to 500 mils of crystalloid to a max of 30 milligrams per kilograms in body weight for the patients with hypotension. If a patient has a lactate of more than 2 or other signs of circulatory shock, such as low urine output, you want to be giving these patients fluids as well. So the lactic acid is a product of anaerobic metabolism, so basically not enough oxygen getting to the tissues. It indicates circulatory compromise, and it can be used to predict how unwell patients are, and it's commonly used for that. And then finally, the urine output. You want to accurately measure how much urine the patient's producing and give them a fluid challenge, and you may need to contact IC about these patients. You may also do a urine dip to rule out any urinary sources of infection. So that's our sepsis 6. So how are we going to go about assessing these patients? We're going to do an A to E assessment, of course. So starting off with airway, the patient's airway is patent and they're able to talk back to you. So if they're speaking to you, you know that the airway is patent. So there's no airway compromise from the submandibular abscess. So you move on to breathing. The oxygen saturations are 97% on room air, which is fine. The respiratory rate is 18. The chest is clear when you listen to it, and you percusp and it sounds normal, and they've got good air entry when you listen. Good air entry bilaterally, and you've got good chest expansion. So that's all relatively positive. Can you think of any potential investigations that you would want to get from breathing? If the patient had low oxygen saturations, you would want to think about an EBG. In this case, you may want to think about a venous blood gas. You may also want to get a chest x-ray to rule out chest as a source of infection. So circulation. The patient's blood pressure is 95/65, which is low. The heart rate is 105, which is high. Capillary refill time is 4 seconds, which is high. And they don't have a urine output because there's no catheter. Disability. The patient's alert. The pupils are equal and reactive to light. And the glucose is 15, which is high. So what investigations do we want to carry out for the circulation aspect of this? So you want to insert a catheter because the patient doesn't have one and you want to know what the urine output is. You're going to give them an IV fluid bolus of 500 millilitres over 15 minutes, which is stat. You want to make sure that the patient has had their IV antibiotics, which is super important. You want to get an ECG because the patient is tachycardic and have been complaining of palpitations. You also want to take some blood cultures and some bloods. So bloods wise, full blood count looking for signs of infection. Using these, check the patient's electrolytes and their renal function if you're giving them medications. CRP for signs of infection, liver function tests to look at their liver function if you're going to be giving them medications as well. Glucose, the patient is hyperglycemic from the blood glucose sample, and a venous blood gas because you can get the results very quickly and it will help you in the management of the patient. What are we going to want to look at from disability? You're going to want to make sure that the patient has had their diabetic meds because he's hyperglycemic, and you may want to consider starting a variable rate insulin infusion. And once the patient's stable, you may want to think about a diabetic nurse review. So we get the patient a venous blood gas sample, and these are the results that come back. You can see there are lots of parameters on this, but there are 2 abnormalities, those being in the lactate being 2.2 and the glucose being 14.5, so they're both high. And just a quick aside, the main difference between a venous blood gas and an arterial blood gas is oxygen and carbon dioxide levels aren't accurate on a venous blood gas. So we only take an ABG if the oxygen saturations are low. So you can look at the oxygen and carbon dioxide levels, but everything else is the same between the 2. So you'd only take an EBG for an unwell patient as well. They take a minute to get the results compared to normal bloods, so you can get rapid results, and you can look at the electrolytes to confirm if there's any abnormalities quickly, usually potassium, and a hemoglobin if the patient's bleeding. So why do we think that the patient's lactate and the glucose are high? What could be going on here? We've already talked about it. Lactate goes up in sepsis, and this patient has a history of diabetes, so the lactate is high because of the sepsis, and we've got a high glucose as well. And to finish off our ATE assessment, we have exposure. So there's no rashes or hemorrhages that you can see. The calves are soft and non-tender, they're not swollen, and the patient has this right-sided submandibular abscess which is associated with the carious lower right 7, which is a retained root. What's the most likely source of infection? It's most likely going to be the abscess that the patient is presented with, isn't it? So you carry out the following interventions. You give the stat 500 ml bolus of saline, which brings the blood pressure up to 110/75 and the heart rate down to 90. You ensure that the IV antibiotics have been given, and then the diabetic medications as well. The ECG showed sinus tachycardia, and you take a set of bloods and blood cultures as well, and you insert a catheter. On an aside, the fluid boluses must be given over less than 15 minutes. And you always have to remember to recheck the blood pressure that there's been an adequate response to the fluid challenge. ECG, always get this reviewed by a doctor. Sinus tachycardia just means that the patient has a fast heart rate, but there's no abnormalities. Look at this, the patient stabilises. Later that day, you're called again by the nurses to see the patient again because they're complaining that he's drowsy. What do you think could be some potential differentials here? So you want to think about what's been going on. You can get an altered mental state in sepsis. The patient's also diabetic. Has the patient become hypoglycemic? You need to think about these sorts of things. So the nurse tells you the patient's observations over the phone. He's got an oxygen saturation of 93% on room air, a blood pressure of 80/60, a heart rate of 115, a respiratory rate of 21, and a temperature of 38.3. What do you think of these? They've gone the wrong way, haven't you? The oxygen saturations are low now, back being hypotensive at 80/60, tachycardic at 115, tachypneic, so a high heart rate at 21, and the patient is also pyrexic at 38.3. So you want to think about again how you're going to approach managing this. So we do our ATE assessment again. Airway, the airway is still patent, the patient is able to respond to you but does appear confused. There's still no airway compromise from the abscess. Breathing, oxygen saturation is 93% on room air, respiratory rate 21, chest is clear with good chest expansion. What are you going to do here? You're going to stick this patient on high flow oxygen and you're going to get an EBG from this patient. So the patient gets an EBG, and that's on the screen at the moment. So you can see that the patient's pH is low. The oxygen saturations are low. The patient's bicarbonate is low. The lactate is high, and the glucose is also high. So the lactate and glucose were previously high on the VBG, but the oxygen is now low. That's likely from the sepsis. But what is causing this low pH? Need to think about some things, what can create an acidosis in the body. So the key is looking at the patient's glucose. That is very high, and this patient is an insulin dependent type 2 diabetic. So this patient is at risk of suffering diabetic ketoacidosis. So what happens is the patient's body can't access the glucose because the insulin isn't working to shift the glucose into the cells. So the patients are having to use fat to gain energy. So they're creating ketones. And ketones are acidotic and they're being released into the bloodstream. So this creates an acidic environment which uses up the base, which is the bicarbonate, causing a low bicarbonate and causing the blood to become acidotic. So this patient is presenting with diabetic ketoacidosis. So we look at the patient's circulation. The blood pressure is 80/60, the heart rate is 115, the capillary refill time is more than 4 seconds, and he has a urine output of 875 mL in 6 hours. Disability, he has no confusion. blood glucose is 23, his pupils are equal and reactive to light. Exposure, the calves are soft and non-tender, they're not swollen. There's some central abdominal tenderness, and there's no evidence of any rashes. So looking at circulation. To treat that, to treat the blood pressure, you want to give the patient a fluid bolus. He needs another ECG to make sure there's nothing cardiac going on. That's a high urine output. Your normal is going to aim for 0.5 to 1.5 mils per kilogram per hour. This patient also needs a urine dip. Bloods wise, you're going to be sending off some bloods. You want to send off a full blood count, Usinase, CRP plus confusion screen bloods. So these are thyroid function tests to look at the thyroid, a bone profile, so that includes calcium, coagulation screen, B12 and folate as well. Okay. So you get a urine dip. Red cells nil, leukocytes nil, nitrites nil, ketones +++, glucose +++, protein nil. So we'll work through what this means. Red cells, so blood in the urine is a common presentation of infection and kidney disease. Also in females, check if they're on their period, simple things like that. You always need to invest blood in the urine in older patients because it can be a sign of bladder or kidney cancer. Leukocytes can sometimes be present in infection, but they're also present due to if the patient has a catheter and because of inflammation. Together with nitrites, it would indicate an infection. Nitrites are positive when the patient has an infection because it's a product of bacterial metabolism. Glucose is present in diabetes when there's hyperglycemia. Protein normally indicates a renal disease because they shouldn't be leaking out in a healthy kidney. And ketones are present in a diabetic ketoacidosis because the body can't use the glucose for energy, so they go into ketosis as we've explained. So what's the most likely diagnosis? As we mentioned before, the most likely diagnosis is diabetic ketoacidosis. So diabetic ketoacidosis is characterised by hyperglycemia of more than 11 millimoles per litre, ketones of more than 3 millimoles per litre, acidosis of pH less than 7.3, and is characterised by ketoacidosis, dehydration and potassium imbalance. So what happens? When the diabetic is not producing enough insulin, the main problems are these 3 points at the bottom that I've just mentioned. Ketoacidosis happens when the cells don't have any fuel and start ketogenesis. So over time, glucose and ketones get higher and higher and higher. The ketones use up the bicarbonate in the blood, and that blood then becomes acidic. Hyperglycemia overwhelms the kidneys and it starts to be excreted in the urine. The glucose in the urine takes water with it, which results in dehydration and excessive urination. Potassium imbalance. So what happens with the potassium imbalance is the insulin normally drives potassium into cells. So without insulin, potassium isn't stored in cells. So it means you have a high potassium in the blood and the kidneys start to filter it out to try and get rid of this excess potassium. So as a result, you get more potassium moving from the cells back into the blood to try and maintain the blood level. So this means there'll be low overall potassium in the cells, but on the blood tests it may be normal. Once the patient starts getting insulin, the potassium is then shifted into the cells and you then get a low potassium, so hypokalemia, and that can result in cardiac arrhythmias. So it's really important to fluid resuscitate the patients with potassium supplementation. So what symptoms do you get with diabetic ketoacidosis? You get excessive urination, so polyuria, extreme thirst, polydipsia, nausea and vomiting, weight loss. You have an acetone smell in their breath, dehydration, and you can get an altered consciousness. Now you may be wondering, why has this patient developed diabetic ketoacidosis? And infection can precipitate it, and it can cause the patient to develop ketoacidosis. If they're otherwise normal, infection can derange their ability to control their blood sugars and precipitate DKA. So in terms of management, you want to correct the dehydration over 48 hours. Normally you use a fixed rate insulin rate infusion. You want to treat the underlying trigger. So as I just mentioned, sepsis is this case of causing it. You want to make sure to replace the potassium, and you're going to be having strict monitoring of the glucose, the ketones, and the pH to assess the progress of the patient. Now, this isn't something you're going to be expected to manage, but it's something which is useful to be aware of. So to conclude the case, the patient is treated for their DKA successfully, and after this is stabilised, they're taken to theatre for incision and drainage of their submandibular abscess. And we'll move on to case number 2. So we have a 65-year-old female. She has a T2N1M0 left floor of mouth squamous cell carcinoma. She had resection and reconstruction with a left radial forearm free flap with bilateral neck dissection. She's day 5 post-operatively and was stepped down to the ward yesterday. Past medical history of COPD, had a previous MI, so heart attack, and has eczema. She doesn't have any allergies. Socially, she smokes 20 cigarettes a day and has done for 40 years and doesn't drink much alcohol. She has a tracheostomy tube in place and they trialled a cuff down earlier today. So we see some bloods from yesterday for the patient, and you can see there's some abnormalities. The white cell is high, the hemoglobin is low, the MCV is low, the neutrophils are high, and the CRP is high as well. So the white cells in CRP are usually high post-operatively because you get general inflammation, but we look at general trends to make sure that they're coming down post-operatively. Neutrophils are also normally raised in bacterial infection and inflammation, so these again can be raised in post-operatively. The lymphocytes are usually raised in viral infection. We can see that the hemoglobin is low, and we've got MCV, which is mean cell volume. So when you take a low hemoglobin and a low MCV, that would be a microcytic anemia. And this is likely because the patient had blood loss for the operation. Do we know what potential thresholds there are for transfusions in head and neck patients? If the patient's healthy, it's normally less than 70. If a patient has a cardiac history, it's normally less than 80. Is there any considerations we want to think about for this patient specifically? Because this patient's a cardiac patient, they think about potentially transfusing this patient, but they decide not to in this case because a sudden increase in blood volume can compromise the flap by causing congestion. So the decision is not to transfuse the patient. So later that day, you're asked to review the patient because they've spiked their temperature. What other information are you going to want to know? You're going to want to know what the patient's observations are. Are you going to want to know what's happened today? Anything new, any changes to the patient. So you get the patient's observations. She has a temperature of 38.4, a heart rate of 100, blood pressure of 130/75, respiratory rate of 19, and saturations of 98% on room air. So looking at the observations, she's pyrexic, so you need to think sepsis in these patients. The patient also is tachycardic, and again that can be a sign of sepsis. The blood pressure is okay, the respiratory rate is okay, and the oxygen saturations are okay, but you want to know, it's good to try and catch these things early. So you look at the patient's bloods. You can see the white cells are raised from 13 earlier. The hemoglobin has dropped for 89 from 97. The neutrophils have raised from 7.7 to 10, and the CRP hasn't raised that much. So the rise in white cells and neutrophils could suggest a bacterial infection. As I said, the hemoglobin's dropped, but the CRP hasn't. And do we have any idea why that might not have increased? It's a lag phase protein. It usually takes around 24 to 48 hours to increase, so you will see an increase in this, but after the white cells have already raised. So how are we going to assess the patient? We're going to do an A/E assessment. So as I said, A/E assessment, we want to identify deterioration early and treat accordingly. we want to consider potential sources of infection. You want to check the medication that the patient is on, including antibiotics. So what are potential sources? You have a surgical site, both extraorally and intraorally, potentially chest infection, urinary infection. These are the things you want to be thinking about. So we do our A to E assessment. Airway, the patient has a tracheostomy in situ and the cuff is down. Breathing, the respiratory rate is 19, saturations are 98% on room air, the chest is clear when you're auscultating and you've got equal chest expansion. So what is the significance of the patient's tracheostomy cuff being down? You want to think about the patient may have more secretions, so it does make them more likely to get an infection if they're struggling to cough those secretions back up. It allows the secretions to go down the sides of the cuff where it was previously up. Any other interventions you may want to think about? If the patient's ill, oxygen saturations are okay, so you may want to think about a venous blood gas. You may want to think about chest x-ray if you were thinking of chest as a source of infection. So looking at the circulation, the patient has a heart rate of 100, a blood pressure of 130/75, a urine output of 15 mL per hour, a capillary refill time of 4 seconds. So that's sluggish, they're tachycardic. The urine output depends on the weight of the patient. Disability, the patient's alert and responsive, glucose is normal at 6.7 and the pupils are equal and reactive to light. Exposure, the calves are soft and non-tender, they're not swollen, abdominal exam is normal, the patient doesn't have any rashes, swellings or any signs of bleeding. So interventions for circulation, going to want to get some bloods, you want to get an ECG because the patient's tachycardic, you may want to consider giving this patient some fluids as well. But what are we going to do next? We're going to do the sepsis 6. So as before, we've got buffalo, so we have the blood cultures, the urine dip, the fluids, antibiotics, lactate and oxygen. So that's what you do. The patient was due to have their antibiotics stopped today. They're currently on IV coamoxiclav and metronidazole, and right now you're not sure what the source of infection is. What should you do? First of all, you should be contacting your senior, probably the registrar. You want to send a sputum sample. You want to look at all the investigations so far, any previous swabs sent off, has there been any urine dips, and you want to speak to microbiology if there is any results back. So we do a urine dip. So looking at the urine dip, their red cells have 1+, leukocytes 1+, and all the rest are NAD, the nitrates, ketones, glucose and protein. What could explain this? So remember, this patient has a catheter in place. So if you've got some blood and some white cells in that, it can be explained by having a catheter there. For UTI, you normally need to have nitrates present because it's a breakdown product of bacterial metabolism. So because this patient's catheterized, we should probably still send a sample off anyway. So you go and review the patient later on the shift. The patient has a productive cough. The sputum sample has been sent and taken. The patient has had a persistently high temperature of above 37.7 and they're now hypotensive at 108/63. Respiratory rate is 28, so they're tachypneic, and the saturations are 92% on air. What does this patient probably have? Sepsis. So what we're going to do, we're going to do an A to E assessment, and we're going to put the patient on high flow oxygen 15 litres via non-rebreathe mask immediately. So we start off with A for airway. The patient's tracheostomy cuff is still down, and there's copious excretions being aspirated by the nursing team. Breathing, the patient's respiratory rate is 28, saturations are 90% on room air, and there's crackles in the lower right zone and slightly reduced chest expansion on that right hand side. What investigations are we going to do? We're going to do a chest x-ray and we're going to do an arterial blood gas. Do we think that we should potentially put the cuff up? It's probably not a bad idea on a patient like this. So we've got this arterial blood gas for the patient. So the AVG was taken on 35% oxygen on 15 litres per minute. So the patient is acidotic, the pH is low. The patient's oxygen is low, the carbon dioxide is high, the lactate is high, and and the patient's hemoglobin is also low. So how are we going to interpret this? Why does the patient have an acidosis? So when lactate is high, it's a lactic acid, it's an acid. So that can create an acidic environment. The patient's carbon dioxide is also high, and that also creates an acidic environment. So that has pushed the pH of the blood down. Sepsis is likely causing the low oxygen saturations for this patient. But why do we think that the patient's carbon dioxide is high? She has COPD. The outflow of air is obstructed, so she can't get rid of the CO2. It's important to know that not all patients retain carbon dioxide normally, and this patient had normal saturations beforehand. But the pneumonia can make it more difficult to breathe properly, and that's why this patient's retaining carbon dioxide in this instance. Note the bicarbonate is a buffer, but this usually takes around 48 hours to rise, but it's normal here. So this is how we know that this is an acute CO2 retention. Okay. So we look at the circulation, heart rate is 120, tachycardic, blood pressure is 108/63, hypotensive, urine output's dropped, capillary refill time is 6 seconds, so that's very long. Disability, the patient is confused, the blood glucose is normal. Exposure, there's no rashes, the calves are soft and non-tender, there's no obvious signs of infection peripherally or on the skin. So interventions wise, you want to get an ECG. This patient is tachycardic. You're going to want to fluid resuscitate this patient, get some bloods, get some blood cultures off this patient. Okay. So you get a chest x-ray from the patient and it looks like the patient has a pneumonia. You review the imaging with your registrar. The bloods you've taken this morning haven't come back yet. The urine output has decreased, like I said, and you want to speak to microbiology on a hospital-acquired pneumonia. That's what this patient likely has. And there's a graduation infection which varies from mild to severe, and it will be important to decide on the treatment for this patient with your senior. So the cultures won't be back yet, but you decide to treat this as a severe hospital-acquired pneumonia, so a HAP, and you commence the patient on tazocin based on the hospital microbiology guidelines, and you start the patient on IV fluids. You give them a bolus and you give them maintenance. So fluid bolus, you may want to consider 250 mils in less than 15 minutes, as the patient has a history of a previous heart attack, so the cardiac function may be impaired. So what do you do next? You've given the patient treatment and you try and stabilise them, but she's still deteriorating despite having the antibiotics and fluids. You discuss with the critical care outreach for consideration of bi-level positive airway pressure, which is a type of ventilation for patients who are retaining carbon dioxide due to some sort of obstruction or restriction. It'd be really important to inform your registrar, as there may be special considerations due to the patient being a free flap patient. This patient has a tracheostomy, so she could be ventilated through this, but if the tracheostomy was out, you would consider BiPAP or CPAP, but these are bad for free flaps because you're blowing high pressure air and it can cause emphysema. So that's why it's really important to always discuss this with the MaxVax team. And we reach the final conclusion of the case. The patient is eventually stabilised and she recovers well from a pneumonia after a short stay in the ICU. When patients are deteriorating like this, it is really important to get the intensive care team to review the patient, and they may consider escalating the patient's care and admitting them. Okay. And as always, we've got our learning resources. There's the On-Call and Oral Maxillofacial Surgery book, which is great. There's the Almost a Doctor website, Geeky Medics, eFace, these are all great other resources that you can get lots of information on these subjects. And again, thank you guys so much for joining us. If you have any questions, you can send an email to the email address below, and don't forget to follow us on Instagram at OMFS DCT Survival.